Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm back with another interesting brain imaging case. I'd like to extend a big thanks to Aaron Commer, one of my colleagues here at IU School of Medicine, who shared this case with me in the first place. So thank you, Aaron, for the interesting case. So as always, I'd like to start out by saying that all of the educational content found as part of this lecture has been completely de-identified in order to protect patient privacy. So the history in this case is a young man, and I'll avoid telling you his age other than to say that it's a young adult, and they presented with progressive gait and behavioral problems. So we have three images to look at. The image on the left is an axial flare. The image in the middle is an axial T2-weighted fat-saturated image at the same level. And then the image on the right is a coronal T1 SPGR image, so one of those high-resolution volumetric T2-weighted images that have been acquired, and we're looking at a coronal reconstructed image of that through the level of the ventricles. So keep in mind that it's a young adult male. We've got a progressive history of gait and behavioral issues. Take a look at these three images, try to piece together what you think might be going on. Okay, so I've got three questions for you. First of all, what are the findings? Second, what do you think the diagnosis is? And then the third question is, what do you think about the prognosis for this patient? All right, so let's take a look at the imaging. First up, we have our axial flare image, and the first thing that probably stands out is that the ventricles appear a bit large. If you look around, there's not a lot of cerebral volume loss, but the ventricles look a bit prominent. So the question is, does this patient have hydrocephalus? And the answer to that is no. This is not a patient with hydrocephalus. There's something else going on here. And the reason the ventricles look big is because we have pretty substantial atrophy in some of the deep gray structures. So as the yellow arrows denote, we have symmetric marked atrophy of the caudate heads, as well as the putamina bilaterally. And importantly, you can also see that the caudate and the putamen are hyperintense. They're a bit bright on the flare imaging that we're looking at here. So now we look at the axial T2-weighted fat-saturated image, and you can see again we have that enlargement of the lateral ventricles, and that's due to that dorsal striatal atrophy, again involving the caudate. You can see the yellow arrows pointing at the small caudate head, and the putamen bilaterally. And that gives the ventricles somewhat of a box-like configuration, particularly of the frontal horns. I mean, they're not perfectly squared off, but they're losing a lot of volume. The brain is losing a lot of central volume, particularly in that deep gray, and that's causing this box-like configuration of the ventricles. And I think we see a better effect on this particular sequence, that bright signal intensity that you can see within the caudate head and the putamen bilaterally. And then the last image to look at is our coronal T1 SPGR image. And again, we have that enlargement of the lateral ventricles due to the dorsal striatal atrophy, again involving the caudate, which you can see denoted by the yellow arrows, and the putamen, denoted by these yellow arrows. And that again results in this box-like configuration of the frontal horns of the lateral ventricles. So as you put this all together, what does this patient most likely have, and what's his prognosis? So this is a patient who has Huntington disease, and this is an autosomal dominant neurodegenerative disorder, and it's caused by a trinucleotide repeat, CAG repeat, that affects the Huntington gene, or the HD gene. And these patients will have a classic triad of movement disorders, the so-called Huntington chorea. They'll have dementia and may have psychosis issues as well. And importantly, the mean age of onset for Huntington disease is usually in the mid-30s to mid-40s. But it's important to keep in mind that a small but substantial minority, maybe somewhere on the order of 10%, may present with a juvenile variant of Huntington's. And they tend to have an onset in their teenage years or maybe in their early 20s as well. Unfortunately, Huntington's has a very poor prognosis. You're talking somewhere on the order of 15-20 years survival on average with the adult onset, but even more rapidly progressive in the juvenile onset, maybe even less than 10 years in age in terms of a prognosis. So unfortunately, it's an untreatable disorder. It's really a terrible disorder to have, and it's important to be able to recognize these imaging findings and be able to help the clinicians figure out what's going on with these patients. So as far as further reading off of this case of the day, this was a paper that was published last year in AJNR, and it was looking at diffusion imaging in patients with Huntington disease and looking at cortical degeneration and seeing if perhaps ADC or diffusivity measurements can serve as a biomarker for cortical involvement. So it's an interesting paper. It looks like in this study they did find that there was increased diffusivity diffusely about the cortex that may even precede demonstrable atrophy. So diffusion imaging may serve as an important biomarker for assessing disease status in these Huntington patients. Okay, so to wrap this up, again, this was a case of Huntington disease. This in particular was a juvenile onset Huntington's. And so the findings you need to know about on MRI, look for that caudate and putamental atrophy. Can also involve the globus pallidus as well. Look for that increased T2 and flare and potentially ADC signal within the dorsal striatum. That's in the past been thought to be a marker of gliosis involving those central gray structures. There is some increasing evidence that cortical diffusivity may be a biomarker, as I said before, and that may show up even before the atrophy is apparent. If you do MR spectroscopy on the basal ganglia in these patients, you may see increased lactate and choline as well as decreased NAA. Sometimes these patients do get a PET scan, and if you do FDG PET, you'll see hypometabolism in the basal ganglia. That kind of makes sense. An important pitfall to keep in mind is that even though the typical age of onset of Huntington disease is probably around age 40, that's a good ballpark number to keep in mind, there is a small but important subset that will present much earlier than this, maybe even up to 10% of cases. And unfortunately, these patients will have a much more rapid disease progression. And universally, the prognosis is poor, but particularly in the juvenile onset, quality of life is bad, and years of remaining life are markedly limited by the disease process. So as always, thanks for tuning in to IU Radiology Case of the Day. I would invite you to follow along on Twitter at NAKuntz, and you can check out our complete collection of Case of the Day materials that can be found on our website at radtf.iuhealth.org/COTD. Thanks so much.